welcome to this video where we are going to do clinical question discussion, right? So let's get started. Question number 1. A female patient of age 36 years visited a general surgeon. She complained of redness, swelling, pain in the thumb of right hand for the past 4 days. Vital parameters were evaluated: pulse 89, blood pressure 130 by 80, respiratory rate 17 per minute, body temperature 101 degree Fahrenheit. Upon physical examination, she has cellulitis, acute abscess were observed in the thumb of the right hand. So she has fever and cellulitis. Surgeon prescribed trimethoprim and sulfamethoxazole in a fixed dose combination twice a day for 5 days. Select the effect of drug on the enzymatic activity in the pathogens. So trimethoprim and sulfamethoxazole are frequently given in combination as antibacterial, and here the enzyme inhibition which is involved is competitive inhibition is involved. So let's have a look. In bacteria, this tetrahydrofolate is vital to be synthesized in the cells, right? It is synthesized from PABA and pteridine. PABA is para-amino benzoic acid. Enzyme involved dihydropteroate synthase. Then next this compound is formed, no need to do the detail, right? Then dihydrofolate is formed, right? So you need to see that sulfonamides, they resemble in structure with PABA. Sulfonamides resemble in structure with PABA. In case of competitive inhibitor, inhibitor resembles in structure with the substrate. So in case of competitive inhibitor, we know that Km is increased and Vmax is not changed. Why? Because substrate concentration is increased. By Km increase, substrate concentration is increased and the inhibitor is not allowed to bind the enzyme, so velocity will not be decreased. So velocity remains same, right? So because sulfonamide act as because sulfonamide is resembling in structure with PABA, it is PABA analog, so it will inhibit this enzyme. Okay. Then trimethoprim is antifolate. It inhibits dihydrofolate reductase, which converts dihydrofolate to tetrahydrofolate, right? So trimethoprim inhibits here, sulfonamide inhibit here, so they both are given in combination as antibacterial, and this is competitive inhibition. Now let's quickly do examples of competitive and non-competitive inhibitors. So arsenate and oxamate, they are inhibitors of glycolysis. Arsenate inhibits glyceraldehyde 3-phosphate dehydrogenase. Arsenate also inhibits lipoic acid, so inhibits link reaction in TCA also, right? Oxamate inhibits lactate dehydrogenase. Then malonate is inhibitor of complex 2 of ETC and succinate dehydrogenase of TCA also. Fluorocitrate is competitive inhibitor of aconitase. On the other hand, fluoroacetate is non-competitive inhibitor of same enzyme aconitase. Then sulfonamide, I already told you, it is PABA analog, it is antibacterial. Then methotrexate inhibits dihydrofolate reductase in the human cell, so it is anti-cancerous or immunosuppressant, so it will kill the human cell, right? Then dicumarol resemble in structure with vitamin K. Vitamin K is doing coagulation, helping in coagulation, acting as the coenzyme for the activation of carboxylation of clotting factors 2, 7, 9 and 10, right? So dicumarol is analog of vitamin K. Vitamin K is in coagulation, so dicumarol acts as anticoagulant. Then ethanol is used in the treatment of methanol poisoning. Because in methanol poisoning, enzyme involved is alcohol dehydrogenase, which converts methanol to formaldehyde, which is very toxic, right? So now we give ethanol as treatment. Alcohol dehydrogenase enzyme has high affinity for ethanol. Even if ethanol present in less amount, this enzyme will bind with ethanol and will form acetate, which is non-toxic. So ethanol used in treatment of methanol poisoning, right? Then statins are competitive inhibitors of HMG-CoA reductase enzyme, which is rate limiting enzyme of cholesterol synthesis, right? So you have to learn which is competitive and which is non-competitive. In non-competitive, now other examples are iodoacetate inhibits glyceraldehyde 3-phosphate dehydrogenase. Sodium fluoride inhibits enolase, which is used in blood glucose estimation. Sodium fluoride is present in the gray vacutainer, which is used for collection of blood for estimation of blood glucose, right? Then arsenate also inhibits alpha ketoglutarate dehydrogenase, I told you. Then cyanide inhibits complex 4 of ETC. Most of the complex 4 inhibitors of ETC or most of the complex 4 inhibitors of ETC are non-competitive. Then disulfiram, which is N-tabuse compound, inhibits aldehyde dehydrogenase. Then diisopropyl fluorophosphate is non-competitive inhibitor of all the serine proteases, example trypsin, chymotrypsin, elastase, etc. Right? So let's do this chart. In case of competitive inhibition, Km increases, Vmax is same. In case of non-competitive inhibition, Km is same and Vmax decreases. In case of uncompetitive inhibition, both Km and Vmax decreases, right? Then question number 2. A neonate born in hospital was normal in first 24 hours. Suddenly neonate started crying and experienced a seizure and became unconscious. Detailed examination and lab investigation revealed plasma glucose. So patient has hypoglycemia, only 35 milligram per deciliter. This neonate was diagnosed with deficiency of phosphoenol pyruvate carboxykinase. So PEP-CK is enzyme of gluconeogenesis. Gluconeogenesis provides glucose to blood. So when this enzyme is not working, the pathway gluconeogenesis is not working. That's why patient has hypoglycemia. So select the substrate that is affected. So the substrate of PEP-CK is oxaloacetate. So there are 4 special enzymes of gluconeogenesis. You should do the substrates and the product. You should do these reactions nicely. So PEP-CK converts oxaloacetate to phosphoenol pyruvate. And one more thing, PEP-CK uses GTP. So GTP is used by this enzyme, very, very important. GTP is required for gluconeogenesis. To make 1 glucose, 4 ATP, total 4 ATP and 2 GTP are used, right? The next question, question number 3. A male patient of age 23 years suffered from shivering, fever, headache, loss of appetite and fatigue. Patient visited the clinic of a physician for these symptoms. Clinical examination and lab investigation were conducted. Malarial parasites were detected in peripheral blood smear and malarial antigen test was positive in rapid diagnostic kit. Physician advised a single dose of Primaquine. Patient reported with fatigue, dizziness, bluish discoloration of lips. So after having Primaquine, he is having fatigue, dizziness, bluish discoloration of lips and pallor of conjunctiva. Physical examination and lab investigation will reveal deficiency of which enzyme. So Primaquine or oxidant drugs, if given to G6PD deficiency patients, they will be having attack of acute hemolysis, right? So this is glucose 6-phosphate dehydrogenase G6PD, which is rate limiting enzyme of HMP pathway, right? Other options, glucose 6-phosphatase deficiency is von Gerk's disease. Von Gerk's disease, which is type 1 glycogen storage disease. Option C, this deficiency is not found. And then 6-phosphogluconolactone oxidase. This is the enzyme which synthesizes vitamin C in uronic acid pathway. Uronic acid pathway, and this enzyme is absent in humans, right? Gluconolactone oxidase, right? The next question, question number 4. A 4-year-old girl presents in clinic with megaloblastic anemia, failure to thrive. Blood chemistries reveal orotic acid urea. So directly diagnosis is given. The cases of orotic acid urea. Enzyme measurements of WBC reveal a deficiency of pyrimidine biosynthesis enzyme, that is orotate phosphoribosyl transferase. So OPRT enzyme is deficient and this is a case of orotic acid urea. Patient has abnormal high activity of enzyme aspartate transcarbamylase, right? Which one of the following treatment will reverse all symptoms if carried out chronically? So blood transfusion, white blood cell transfusion, dietary supplements of PRPP or oral uridine. So this is a defect in pyrimidine biosynthesis pathway. Pyrimidines are not getting formed. That's why patient has megaloblastic anemia, right? So pyrimidines are U, C and T. Uracil, cytosine and thymine. So in the pyrimidine biosynthesis, we know that U is formed first and this gets converted to C and T. And in this patient, pyrimidines are not formed, but there's no need to give all the pyrimidines. We give U in the form of uridine and C and T will be formed in body, right? So this is the treatment of orotic acid urea, right? Next question, fifth number question. 6-year-old female is being evaluated for recurrent episodes of lightheadedness and sweating due to hypoglycemia. These symptoms are not improved by subcutaneous injection of epinephrine, right? So normally epinephrine will cause hyperglycemia, but here it is not causing. Physical examination reveals enlarged liver, single subcutaneous xanthoma. So xanthoma means triglycerides or lipids are increased. An abdominal CT scan reveals enlargement of liver along with bilateral enlargement of kidney. So kidney and liver are enlarged. Increased serum uric acid and cholesterol with decreased serum glucose. Yes, they have already written hypoglycemia. Following oral administration of fructose, there is no increase in blood glucose levels. A liver biopsy specimen reveals increased amount of glycogen. So it's a glycogen storage disease and it is von Gog's disease. Type 1 glycogen storage disease. Patient has severe hypoglycemia, ketosis, massive hepatomegaly. Spleen is not found to be enlarged in these patients, but kidneys are enlarged. Patient has lactic acidosis, hyperuricemia, hypertriglyceridemia, and usually doll-like round face because of deposition of lipids, right? So this question is a very typical case of von Gog's disease, which is very, very important. Enzyme deficient is glucose 6-phosphatase, which is common enzyme to two pathways, glycogenolysis and gluconeogenesis, right? So this is very, very important. You should revise this disease before your exam. Next question. A male infant presented with neonatal seizures, lethargy, but neither has ketosis nor hematologic abnormalities. Treatment with a low protein diet and glycine binding agent started and improvement was seen. What is the diagnosis? This is a case of non-ketotic hyperglycemia. So I wanted to teach you this disease. This is important. I have not taken the options here, so it doesn't matter. So see this non-ketotic, so the name of the disease is telling you there is no ketosis, right? Non-ketotic hyperglycemia. Now here the defect is in glycine cleavage system. In body, glycine cleavage system is there, which will break down glycine into carbon dioxide and ammonia. This is not occurring. So glycine will be increased. Glycine is getting formed in body also, glycine is coming in diet also. So, and glycine is not broken down. So there will be increased glycine in blood. From blood it will be going to urine also, increased glycine in urine also. And glycine is an important neurotransmitter. So there's increased glycine in CSF also. So increased glycine in blood, urine and CSF. And this is called glycine encephalopathy. Brain is affected. This is known as glycine encephalopathy, right? Then next question, insulin promotes lipogenesis. Insulin is anabolic hormone. So it will help in fat synthesis. Lipogenesis means fat synthesis by all except. Option A, it decreases cyclic AMP. Yes, insulin decreases cyclic AMP and the opposite hormone glucagon increases cyclic AMP. Then insulin increases glucose uptake. Yes, with the help of GLUT4 present on peripheral cells, adipose tissue, muscles, right? So GLUT4 channel will be opened in the presence of insulin, and glucose will go from blood to cells. Glucose will go from blood to cells with the help of GLUT4, which is activated by insulin, right? So insulin decreases the blood glucose, but it will give glucose to the cells, right? Then option C, it inhibits pyruvate dehydrogenase. Pyruvate dehydrogenase is link reaction. Link reaction is activated by insulin. So link reaction is pyruvate to acetyl CoA. This is activated by insulin. This is activated by insulin. So insulin increases the formation of acetyl CoA, so that acetyl CoA is used for fat formation, right? So this is wrong. Then option D, it increases acetyl CoA. Yes, by activating link reaction, it increases acetyl CoA. So they are asking insulin promote lipogenesis by all except. So answer is C, right? Then question number 8. 8-month-old baby girl, when did not respond well to breastfeeding, was put on cow's milk-based formula at 4 weeks. In next few weeks, she was repeatedly admitted to hospital for complaints of screaming after feeding. Suspecting it to be lactose intolerance, attending physician eliminated milk from her diet, which did not improve the condition. So they are telling in the question that it is not a case of lactose intolerance. So answer is not lactase deficiency, right? In the starting, they have given that she is not responding well to breastfeed or milk. So that is going to confuse you. But when you read carefully, this has not improved the condition. Removing milk has not improved the condition means it is not lactose intolerance case. Her parents later observed that screaming bouts were initiated after the child drank juice. Now juice has fructose, lots of fructose, fruits have fructose, right? Now this causes gas and distended abdomen. Lab examination shows no enzyme deficiency in liver. So in case of fructose metabolic disorder, the enzyme aldolase B is present in liver. So they are telling you that it is not aldolase B deficiency because liver enzyme is normal. There is no deficiency of liver enzyme. Physical examination shows no abnormal growth. So biopsy of intestinal tissue from the patient would most likely reveal deficient or defective. Options left are GLUT or SGLT, that is glucose transporters, and fructose is transported via GLUT5. GLUT5 is the transporter for fructose. So very clear that answer is GLUT5. Once you read the question very carefully, then lengthy questions are in fact easy for you. So much information is already given in the lengthy question, right? Then next is 9th question. Female neonate born full term, failing to thrive, not gaining weight. Physical examination showed small head, hypotonia, low muscle mass. Patient has metabolic acidosis with highly elevated pyruvate, lactate and alanine. When pyruvate is increased, then it gets converted to lactate and alanine. So these will be obviously increased. So persistent acidosis which did not go away with thiamine supplementation. So it's not a case of B1 deficiency. So enzyme most likely deficient in this patient is. So this is a deficiency of link reaction enzyme, pyruvate dehydrogenase complex deficiency. This enzyme requires B1. So the similar picture of lactic acidosis can occur in B1 deficiency, very also. But in the question they are telling you it is not a case of B1 deficiency. So it is genetic enzyme deficiency, pyruvate dehydrogenase, right? Excess pyruvate will be there because the substrate of this enzyme is pyruvate, right? Then last question in MCAD deficiency, during starvation, which of the following is correct? MCAD is medium chain. It is for medium chain fatty acids, medium chain acyl CoA dehydrogenase enzyme. This enzyme breaks down 12 carbon fatty acid in beta oxidation pathway. But now beta oxidation pathway is not occurring because this enzyme is not there. So this 12 carbon fatty acid will be going to omega oxidation. In omega oxidation, dicarboxylic acids are formed. So this will lead to dicarboxylic acidosis in these patients, right? And any defect in beta oxidation any defect in beta oxidation leads to non-ketotic hypoglycemia, right? So let's see the options. Normal blood glucose, no. Patient has hypoglycemia. Ketoacidosis, no. Ketone bodies cannot be formed. Dicarboxylic acidosis, yes. Option D, hyperchylomicronemia. Chylomicrons are formed in fed state after taking fat-rich diet. So question is asking you starvation. In starvation, chylomicrons are not possible. So which is correct? Answer C, dicarboxylic acidosis, right? So this is it with this video. Thanks for watching and best wishes for you. And I suggest you do clinical biochemistry nowadays because the question pattern is fully changed for you. So do biochemistry in a way that it helps you in other subjects, other clinical subjects also, and make your base strong by doing biochemistry nicely, right? Bye-bye.